Okay, so today we're going to be continuing with respiratory. We're going to be continuing with lung cancer and chest tubes. So feel free to just ask me questions if you have them. It's just me and you right now. So I'm just going to kind of go through it, or if there's like something you don't understand, or if you want a visual diagram. So lung cancer, you know, it's one of the main, it's the main cancer people have that people die from, one of the main leading cancers in the US. So it's a big deal. Obviously, when we think of lung cancer, the first thing we think of is smoking, right? And it's true, smoking does cause 90% of all lung cancer deaths. But there are people that get lung cancer that have never smoked a day in their lives. And they're like, how did this happen? You know, I don't understand. So we got to know that there's other risk factors, right? Not just smoking. And I guess I could list them on the board here. So risk factors, obviously smoking is going to increase your chances. What is it? I think if you're a woman, it's like 25.7% increase in likelihood that you get lung cancer if you smoke, and for men it's like 25.1. So it's basically the same, 25% increase. I think that's what the note said, the PowerPoint. Smoking, chemicals, like if you are working at like a job where you're, you know, those people that like do carpets and spraying like that, there's just like asbestos and radon, which if you're constantly exposed to that, or maybe if you constantly are, I don't know, spraying, you know, spray paint all the time and not using a mask or something. So chemicals related to your job, air pollution. I visited China a couple years ago, and let me tell you, it was bad. Like, like, you know how like in those post-apocalyptic like end of the world movies, the like you see the skyscrapers and like the sky is black and it looks like the end of the world has come. That's what like China looks like on the regular. Like I was there for like 10 days and I swear it just looked gray and dark all the time. And I was like, is it like cloudy? Like, oh no, this is just, and I was like, where's the sky though? Like it was so bad. Like the pollution's really terrible. It's like I had to wear like one of these little masks that we wear like for COVID and stuff, just because I couldn't breathe. Like I felt like I was just like inhaling all this stuff. And I was like, how do people live? I guess you get used to it when you live there. But I was like, I swear to you, I was like, everyone here's gonna get lung cancer. I don't know. I don't know how they do it. I was only in the major cities, obviously. Like I didn't go to like rural parts of China, but like, you know, Shanghai and all these different big cities. So pollution, if you have chronic lung issues, so people with like cystic fibrosis or COPD or emphysema, like long term, just like a constant lung issues, more likely to get lung cancer. It's also hereditary, so it can be passed down, which is unfortunate. And also in line with smoking is secondhand smoke. I forget like what the actual like stats are, but it was pretty significant. Like secondhand smoke is almost as bad as regular smoking. So people are like, oh well, I don't smoke. It's like, well, the people in your house smoke? Like, yeah. It's like, okay, well, you're essentially smoking because you're breathing in the smoke. So it's not quite as bad, but it's pretty bad. So all of these things will set you up for more likelihood of having lung cancer. Obviously, you can't control hereditary, but hopefully you can have a good control over some of the other ones. Now, there's two different types, or I guess two different main types, and then there's subtypes. The two different main types of cancer is the small cell and the non-small cell. So I guess I can erase this. So the small cell is also called, remember? She said oat cell. Oat cell. And I'm not exactly sure why they call it oat cell. The only thing I can like vaguely remember from back like in the ancient history when I was in nursing school was that like when you look at the you know, you can get like a biopsy and look at the cells under the microscope, that they look like Quaker oats. You know, like have you ever seen a Quaker oat? Like not, you just like kind of look at them, they kind of look like that. I guess they're like, oh, this looks like oatmeal, and they started calling it oat cell, and that's the small cell. This is the one that's super deadly, the one that's the most malignant, the one that is likely to spread to other parts of your body, or fancy word, metastasize to different parts of the body. So like they might start in the lungs, and the lungs is kind of a really bad spot because like the lungs provide oxygen to everywhere, right? So it's not like any part of the body is going to come in contact with blood and stuff that's passed through the lungs at some point, so it's easy to spread, right? Same thing with like the heart. I don't know if you get really like heart cancer, I guess you could, but like it again pumps all the blood throughout the body. Yeah, it's the fastest growth. I think it's something like you have a 5%, what is it? A 5-year survival is like, what'd you say?
So 5-year survival, it's 5 to 10%.
Yeah, so 5-year survival is 5 to 10%. So that's not very great. Like you have a 5 to 10% chance that you'll live longer than 5 years. So that's pretty small. So it's unlikely that you're going to be one of those 5 to 10% of people that are going to live that long. So it's pretty much like, yeah, that's kind of a quick diagnosis there. So that's the one that's most associated with smoking. So you can get lung cancer from not smoking, but if you do smoke, you're more likely to get small cell. The other one, the non-small cell, which people also will call this NSCLC for non-small cell lung cancer. This flick. Yeah, that's also, then there's like different types under that. So you have the small cell and non-small lung cell, and then within that type you have, I think 3 was mentioned in your PowerPoint. There's the squamous cell. Spelled that wrong, it's fine. The adenocarcinoma, and what's the last one?
Large cell carcinoma.
Yeah, large cell. So I don't think there's really anything to know specifically about that, except for that those just fall under the category of the non-small cell. Basically, if it's not small cell, it's non-small lung cell, right? And then I think also they mentioned that for adenocarcinoma that typically is in Asian women. Is that correct? I remember that just because it starts with an A, adenocarcinoma and Asian. So just, one of those things, kind of put words together, make it easier to remember. Any questions so far about any of this? I'm going to erase this. All right. Okay, so let's say someone has lung cancer. What are some, using our critical thinking, what would be some signs and symptoms that we would expect to see in someone with lung cancer? Yeah. What kind of cough, though? Yeah, cough that doesn't go away, just kind of always there. What else might be part of the cough? What might they cough up?
Oh, like sputum.
What kind of sputum? Blood. Yeah. So coughing up blood, generally a bad sign, right? It's like, maybe blood isn't supposed to be coughed up. They call that hemoptysis, a fancy word. Let's see if I can spell this right. Hemoptysis. Yeah. So that's just a bloody cough. Generally a bad sign. Have you ever seen the movie? I don't know if this is actually the name of it, but is it The Bucket List? Is that the name of the movie? I think, okay, anyways, it's about this guy, he's living his best life, and then he's in court one day, I think he's a lawyer, and he coughs into his handkerchief and he sees blood, and it's like, oh shoot, and then he realizes that he has lung cancer and he only has a few months to live. So it's probably the small cell that we learned about, right? And so now he starts going off and checking off his bucket list of all the things he wants to do before he dies, and jumping out of a plane and all this stuff. Good movie, but also relevant to what we're talking about. I like to when I see movies like that, I'm like, oh, that's hemoptysis. He probably has small cell lung cancer, just like and annoying everyone else who's watching the movie with me. Anyways, okay, so what else? You said wheezing, right?
Yeah.
So wheezing, what does that sound like when you're listening?
I don't know, like a high pitched.
Yeah. High pitched, you'll hear it. Sometimes you don't even have to have your stethoscope. Like sometimes you can just hear it from across the room. That's how bad it is. You'll hear like, I can't make myself wheeze, but it's like this high pitched kind of like, and you can kind of see like their body kind of like groaning and straining too, from airway constriction. That's where you get like the whistly sound. Because like whenever you like narrow an opening, they were like blowing on the top of a Coke bottle and like makes that sound, and then if they make the whole size bigger or smaller, it'll like either go up and down in pitch. That's what happens like when you close the airway and tighten it, you get wheezing. So like people that have asthma, if they're having an asthma attack, you might hear wheezing because their airway is constricting. So you give them albuterol and it helps open up that airway, gets rid of the wheezing. Persistent cough, dyspnea, just difficulty and pain with breathing because there's cancer in their lungs. Hoarseness, so with their voice kind of like having a hoarse throat. That kind of goes with the persistent cough, right? Because if you ever cough a lot and you kind of lose your voice, like it just kind of like irritates the vocal cords so much from coughing and all that. So like the irritation of the vocal cords can lead to the hoarseness. And then if you also have just for whatever reason you keep having just like recurrent infections like pneumonia, bronchitis over and over again, like just getting these lung issues, it might be a sign and symptom that you are developing cancer. So like someone has 3 bouts of pneumonia in a few months, which is abnormal. So go ahead and erase these. Any questions about the signs and symptoms? Was there anything else on your notes that I missed?
Just chest pain from like freshman.
Oh yeah, chest pain. Typically chest pain is going to be a sign and symptom of anything respiratory or cardiac. That's a freebie.
Yeah.
If you see that, circle it on the test because it's correct. Okay, so we suspect that someone might have lung cancer because they have several of these side effects that we just saw, or signs and symptoms, I should say. How are we going to diagnose them for sure? How are we going to check them out?
Like do chest X-ray.
Yeah, those are obvious. X-ray, what other imaging? Yeah, MRI, CT, I think there's a PET scan. So all these are just different ways to image and look at the lungs, right? You can be able to see, if you can see a tumor or whatnot. There's also the TNM rating system, which is just a way of measuring like the rate and the growth and the fastness of it spreading. And do we know what it stands for? So the T stands for tumor size. So they'll be able to, like, if they are either via an X-ray or via like a scope looking inside the lungs, they'll be able to say, okay, how big is this tumor? If it's really, really tiny, probably an earlier stage than if it's like ginormous and it's like probably a larger stage, like stage 1, 2, 3, 4, or whatever. So tumor size, the N stands for nodes. So like lymph nodes. Typically when stuff is spreading or metastasizing, I should say, it travels, not always, but a lot of the times through the lymph nodes, because a lot of our immune system is in our lymph. I don't know if you remember like the lymphocytes from AMP, which are part of like the white blood cells. So a lot of our immune system is located in our lymphatic system. And so if there's like swelling of the lymph nodes or lymph node involvement around the area, we can tell that it's spreading, it's getting worse. So if it's bigger size and if it has lymph node involvement, we're like increasing our staging, right? And then M stands for metastasis or METs. You'll see METs a lot just for short. If you see METs in a chart, that's what that means. And that just means it has moved and redeposited somewhere else. So like cancer cells can get dislodged and get in the bloodstream and float somewhere else and then lodge there and start growing there. So this is one way of being able to stage kind of like stage 1, 2, 3, 4. They use like X-ray. They'll use the TNM system to kind of figure out like what level of cancer you have. Another one you can do is sputum cytology. It's where you like analyze what's going on with the patient's sputum, and this is different than spit. Like spit is just, you know, stuff in your mouth, but like sputum comes from like deep within you. It's like the more mucusy stuff. So like collecting sputum cultures is never fun, because patients always just want to like spit in the cup and give it to you. And it's like, no, sorry, you're gonna have to like hawk up a loogie. So they look at that. I'm not sure exactly what they do with it. Maybe test it to see what kind of cells are in there, or how much immune cells are in there. Not exactly sure. I'm not an expert on sputum cytology, but they do sputum cultures for various things to see like, what kind of bacteria are growing. They do that a lot for like seeing like if someone has pneumonia, like which antibiotics will work well against, testing the resistance, because some pneumonias are not going to respond to certain bacteria. So I guess they're trying to rule out like maybe if it's really bad pneumonia versus lung cancer or something. What else? Okay, so there is also, I don't think your notes had this one, but I'm just going to mention it because it was in my notes, but it's just, I'm not sure if it was in your notes, but like when I open up the PowerPoints, like always half of the PowerPoint is cut off for me. So I never know if I'm what's missing in the top half. So I'm always like, well, okay, so it could have been there. So I'm not sure. Did you have anything in your notes about a bronchoscopy? Okay, so it probably was in the half that was missing out of what I could see. Perfect. Okay, so the bronchoscopy, and then there's a thoracoscopy and a bronchoscopy. So the difference with that is, let me draw a picture. Actually, I feel like it'd be easier. So bronchoscopy with biopsy. Let's draw our favorite man here. Okay. This is our man with his lungs. I'm gonna have to do better at lungs. So bronchoscopy, a tube is going to go through either the nose or the mouth, down the trachea into the lungs, and they're going to look around. Let's say the tumor's right here, and they're going to take a biopsy of it. You know what a biopsy is? They take a little needle and kind of like suck some of the cells into it to take as a sample to go look under the microscope and see if it looks like an oat or Quaker oat. So they'll take it out that way. So that's a bronchoscopy. Does your note say anything else about that? Because I didn't see it.
No, it just says like patient NPO.
Yeah. So obviously, if you're putting something down their throat, like a scope down their throat or down their nose, it's going to mess with their swallowing, because it's got to go bypass that, right? So it could have messed up their ability to swallow correctly if it damaged anything going down, right? Which it could. It can also mess with their gag reflex. So keeping a patient NPO until we know that they're safe to begin drinking or eating again, just to make sure like they have a gag reflex and that they're not going to aspirate all this water after you just did this procedure on them. So that's good patient teaching to be aware of. Hide the water from the patients because they will go get it. They will. Okay, then I always say it's so hard to say. Thoracoscopy. I always want to say thoroscopy, but that's not it. Thoracoscopy. This one is when they go actually like through the chest. So rather than like going down the trachea, they're just going to go through like one of your like spaces here, like through the ribs, with a video assistance. So they're not going to just blindly just like jab you, but it like goes through the chest wall with a little video camera. So that's a video camera, and they kind of look around. And the benefits of this one is they can like see everything. They can directly like visualize the tissue and stuff. They can get a good sample from the biopsy. Obviously, this comes with different post-op, right? Like NPO isn't as much of a thing because it doesn't go through their throat. but you wouldn't want to worry about checking for like bleeding at the site. Make sure you're monitoring what sounds, lung sounds, right? Because if it got messed up or whatever, like their lung could be collapsing, giving a pneumo or a hemothorax, right, from it literally puncturing through. They're gonna need a chest tube probably after this. So I feel like this is, more invasive, but it does come with like some benefits. Generally you want to start with like the least invasive, which would be like this one, but this one does have certain advantages if it's like far along or if they really need to see everything really well or something. And then there is a thoracentesis, which is kind of like a biopsy, but with fluid. They insert a needle like into the pleural space. So like, they have like the pleural cavity and then you have the lungs, right? So like, remember, I guess that, like when we talk about the heart, we talked about how like there's fluid surrounding it. So they'll take a needle, go into the pleural space and extract some of this fluid to look at it again for, I don't know, seeing what's in there. Maybe there's some cancer in there or some immune mediators or whatever they're looking for to figure out what's going on with the lungs. They'll take some of that fluid out and look at it, do their fancy science on it. So that's a thoracentesis with a needle and a syringe there. This thoraco one. This is the tumor. So, any questions? Did I miss anything?
She mentioned the percutaneous lung biopsy.
Okay. Oh yeah, I remember this one. But I'm not sure honestly what the difference is between the percutaneous and thoracoscopy because they're both going into the lung to get a biopsy. So not really sure what the difference is. What does your note say?
Local anesthesia, CT guiding, and then it gives like post-procedure nursing stuff. So.
Yeah, so I mean, either way, you're gonna obviously want like anesthesia because you're literally going inside their lung.
Yeah.
So that might be uncomfortable, so pain medicine. But as far as like the technical difference between the percutaneous one and the thoracoscopy, I'm not really sure. I didn't have that one in my notes from when I was in school, but I did briefly see that on your PowerPoint, and I was like, okay, well, what's the difference though? I don't know if there will be a super big. Yeah, it's not even in my note.
Okay.
So maybe just knowing that it exists.
Yeah.
And then the local anesthesia part, which would make sense before you puncture someone's lung, you're gonna want to make sure it's numbed up. Okay, are we good with this one?
Yeah.
Can you erase this one? Maybe the difference is that like this is the thought. Perhaps the percutaneous one is literally just putting a needle in to get a biopsy. Like let's say like the tumor is right here and they know it's right there and they're just gonna stick a needle in and biopsy it. Versus like thoracoscopy, they're inserting a scope to like look around with a camera, right? So maybe that's the difference. One's like they're looking around and it has to go in more versus like it's just inserting a needle and taking it out. That would be my thought. Okay, so person has lung cancer. What do we do now? How do we treat this? What are some options for this person? We've got 3 options moving forward. Surgery is one. Next one is what?
Medications.
Yeah, chemo, medications, and then radiation. Or do nothing is also an option, I guess. So chemo and radiation are pretty straightforward. I don't think they go too much in depth about that. They kind of just mention it, right? Okay, yeah, they don't. I feel like they go into more about that stuff on like the cancer lectures, which I don't know when you guys have that. Okay, so there's different types of surgeries. There's 3 different types that we're going to talk about. So I'll erase this so I can draw a picture. So there's a wedge resection, there's a lobectomy, and then there's a pneumonectomy. Is that what you have on yours? Okay, so I am really bad at drawing lungs. I need to like look at this picture because every time I try to draw them, it does not look like a lung. That's better. I should have just looked at a picture from the get-go. Sure, that's long. Okay, so a wedge resection is the least bad, right? It's the least invasive. I mean, they're all invasive because it's surgery, but it's the least, like, I guess, traumatic because you get to still keep your lungs. So, like, let's say there's a tiny spot of cancer right there, right? And it hasn't spread yet, and it's localized, and it's small, and it hasn't taken over everything, right? So what they'll do is what's called a wedge resection is they'll just like cut out this portion, right? So this portion now is cut out, and then they'll fancily like close it. I don't know how to draw that, but like they'll like bring these parts together and just wedge it. Does that make sense? Yeah. Wedge resection. So that's the first one. The second one is a lobectomy. So you know how lungs have lobes. So let's just, oopsies. So let's say this is one lobe and this is the other lobe. So let's say this lobe has, let's say this lobe has cancer. It's kind of like, all right, well, can't really do a wedge resection. So we're just gonna cut off the whole lobe, right? So it hasn't spread to the other lobe yet. So we'll just take out this whole lobe. You still have all the other lobes, right? So you should be fine. You're not Olympic athletes. It's not like you need to like necessarily have all this lung capacity, especially people that are like, especially if it's a smoker, you know, they already have bad lungs anyways. They're probably not like hiking up mountains. So, you know, having a lobectomy, they're still gonna be able to breathe, right? So that's the second tier of severe lung surgeries is the lobectomy, where you get rid of a whole lobe. Then the third one is the pneumonectomy, where you literally take off like an entire side of your lung and get rid of that. So now you're relying on like just one half of your lungs to do the job. That seems pretty like crazy, doesn't it? Like, can you imagine like watching someone's chest rise and only like half their chest is like moving, the other half is like not moving? It'd be really weird. So they legit take out the entire lung and just like hope that that one lung is going to be enough. So there are a few things, patient teaching and post-op considerations that you need to know for a lobectomy. So this one, where they take out just one of the lobes, but leave most of the rest of it there. You're going to need a chest tube, right? So you just had major surgery, removing a big thing. There's going to be probably a lot of bleeding. Let's say this is the person's chest. That's their arm over there. So you're going to insert, well, we aren't, but someone will insert the chest tube right around here, right, to collect all of the fluid and the blood that's going to collect. So you're definitely going to need a chest tube. And then are you going to tell the patient when they're laying in bed to lay on which side? So let's say they had their left lobe taken out. Am I going to want to lay in bed on my left side or my right side? Right side. So you're on the unaffected side, right? You don't, you know, that's going to help with the not getting squished. So where did I write this? Unaffected side. Okay, now with a pneumonectomy, it's the opposite, right? So literally everything I just said in reverse. So with a pneumonectomy, you do not want to have a chest tube, and you're going to want them to lie on the side they have their lobe taken out. So if they have their left lobe taken out, you want them to lay on that left side. And I know that sounds weird, but it's like, okay, why? And here's why. So, sorry. So they have this huge, massive like space now inside their chest that's like empty. I mean, because lungs are pretty big, right? And they take up a good amount of space in your chest. So now if you take off like an entire lung, you've got this like gaping hole, right? And so fluids are going to come and blood is going to come and collect in that area, right? And it's going to be a lot because it's a big space. Now, let's say it was my left side, right? If I'm lying on the unaffected side, like you should with the lobectomy, all that fluid now is gonna like fall onto the good lung. Like, if that makes sense, like the gravity of the fluid is gonna be like sitting on top of the good lung and like put all this pressure on it, and it might make it collapse. You could end up getting what do they call it, what's it called when the tracheal moves? What is it?
Tracheal deviation.
Yeah, tracheal deviation. Because it's like, if you see that, it's like, okay, like the lung is like shifting and moving, and like all this pressure from the weight of the fluid is like pressing on it. So they tell you to like lay on the other side to keep that one lung up, the good lung up. So none of that extra fluid is going to press on it and make it collapse. So literally sounds like the opposite. And we want that fluid to come and like fill in that dead space. So we don't want a chest tube. And also there's not really a lung there either, so you can't really like put a chest tube like in the lung if it's not there. So does that make sense though? So just remember those are literally exact opposite things. So what you do for a lobectomy, do the exact opposite for a pneumonectomy. That makes sense?
Yeah.
Okay. It's pretty much. Was there anything else about lung cancer? Let me flip through my notes here. Let's see if there's anything I've missed. Oh, there's subcutaneous emphysema. What's that?
That's the corpus with air.
Yeah, so let's say you've got a chest tube in, and because someone has a pneumothorax. So let me erase this. This is actually going into our chest tube talk, so this works perfect. So let's say this is the person's lung and it's like collapsed, and it's like this is the pleural cavity where it's supposed to be filling up all this, but it's a collapsed lung, so now all this is air. So all this is air, right? So if you have your chest tube and some of the air, let's say that the chest tube just isn't placed well. And sometimes they're not. Sometimes they're kind of like half in, half out, or they get dislodged when patients move around. Some of the air in here might start to leak out and not go through the chest tube, but like kind of leak out into the skin. And this is your skin. So all this air is kind of just in the skin and start to make these like bubbles under the skin from where the air is. And that's called subcutaneous emphysema or the crepitus. It literally looks like they have air bubbles under their skin because they do.
I got to see a patient yesterday that had it.
Oh, you saw it?
Yeah.
What was it like? I have actually never seen it in real life.
Well, he pulled out his chest tube.
Oh, good. I love it when patients see that.
So he was like from head to toe, and they let me feel like the kneecap felt like respiratory.
He had it all over his body.
Yeah. And they'd been pushing it out like throughout the day, like through this hole in his chest.
Oh my gosh, that's insane. Yeah. So all the air inside the pleural space that's collapsing the lung is escaping under the skin. And you said that they were pressing it out through holes. So like, yeah, that's actually they can like put a hole in your skin here, and you can kind of like massage the air to come out that way. That's just so weird to me. Like, I would love to see that. That's just wild. I'm gonna erase this now. So was he confused, or why did he pull his chest tube out?
Well, it's in ICU, so yeah, I think he was confused. He's now like sedated.
Yeah. It's like, sorry, you lost your awake privileges. Okay. Let's see. Is there anything else in here? Patient teaching, always good to teach them to stop smoking because all these reasons, right? What are some medications that can help reduce the desire to smoke?
Gum or
So nicotine gum, Zyban, which is specific for Wellbutrin, which is also an antidepressant. So if someone's depressed and smokes, that's be a great one to give them. Chantix, which blocks the nicotine cravings, so they can smoke, but they won't get any of like the benefits of it. That's always something you can do. Like I've legit seen patients like with a trach, like go outside to smoke through their trach, and I'm like, have you not learned? Like this having a trach placed wasn't enough of a wake up call, you know. Anyways, I think there's the only other thing I didn't say was just calculating pack history, but that's I feel like really easy. It's just a simple to calculate how much pack years. It's just pack years. So how many packs per day have they smoked? So let's say someone smokes 2 packs a day, which people apparently do. And then how many years have they been doing that? So let's say they've been smoking 2 packs a day for 30 years now. You just multiply the 2, right? So 2 times 30, that gives you 60. So their pack years, right? You say they would have 60 pack years. That's the answer. So just how many packs a day times how many years. That's pretty much it. So very easy. They use this number to kind of estimate like how much risk you are for developing like lung cancer. Like if you have a smaller pack years, then you're like on a lower risk. And if you have a higher pack years, you're on a higher risk. If that makes sense. So yeah. That's pretty much it for lung cancer. Not too hard. No crazy oh, I caught that. No crazy patho or anything to try and remember, not like CHF where it was like all this information. Were you there for my CHF one? I wasn't. No. All right, so the next one is just chest tubes, which also is not terrible. Let me use my other notes. Okay, so chest tube. What is the purpose of a chest tube? Yeah, exactly. So chest tube is literally there. Why are these markers all sucking? So to reinflate lung. What are 2 reasons or 2 causes that could be causing the lung to be not inflated or collapsed? Yeah, so it could be fluid or blood, right? A hemothorax, right? That's much easier to see. Okay. A hemothorax, right? Or it could be air, right? A pneumothorax. So these are the 2 things we're trying to fix. So it could be collapsed from either one of those. So the chest tube does 3 different jobs. There's 3 different parts to it within the chest tube. And I wish I could like project an image of it somehow on the screen, but I don't know how to do that. The first part of the collection tube is the drainage part. This is where if it is related to like blood, the blood will collect in here. The second part is there's a water seal. And the third part of the chest tube unit is there's a suction component. So these 3 things make up the chest tube. I really don't know how to draw one of these, but there's like, here's the tube that's going into a patient. And then there's like these collection like columns for the blood, and they have like measurements on the side. So you can see how many mLs are filling it. So we'll just pretend that's 100 mLs. And we'll say that's 50 mLs, I don't know. And so like when it starts filling up with blood, you can like measure it. And one of the things that like nurses will do is they'll get like a permanent marker and mark directly on the box, and they'll draw a line to where like when they start their shift, they'll mark it there and put like the date and time, so that by the end of the shift they can see how much it's filled up past that, and then for any shifts beyond them they can see the trend, right? Because one of the things you really want to watch with chest tubes is the output, right? Like if it's, putting out 80 mLs an hour regularly and consistently, as you can see marked by the other nurses, and then all of a sudden it just stops, like no output. Like, are you happy or are you concerned? You should be concerned, right? Because it's like, okay, it shouldn't go from like producing all of this output all of a sudden none. Right? If it was healing and like it would just have like a slow kind of trickle. But if it just kind of suddenly stops, it's like, there's probably a blockage or something got kinked, and that's bad because then the stuff isn't being able to come out. So it's like a buildup, right? So if we can see that it's seeing the trends is really important. So like monitoring, like, okay, like he's been consistently putting out 50, the next day he's putting out 40, the day after that he's about 30, like we're like, okay, it's healing, right? Versus like, oh, it just suddenly stopped out of nowhere. Does that make sense? So that's the drainage component. It collects the fluids. If it says if there's more than 100 mLs an hour that you want to like notify the physician, because that's a lot of blood to be losing, and there could be maybe something that's not right, like maybe they need to be sutured, or like maybe they punctured something that shouldn't be bleeding, like active bleeding, versus like just draining out what's in the space, if that makes sense. So we obviously don't want to see tons of outputs. Like, okay, we need some of that blood in your actual body, right? So no more than 100. Look out for abrupt stops, right? Slow, tapered off stops are good. That means it's healing. Second thing, the water seal. There's gonna be like, I think this is the bottom left, right? Okay, so the bottom left, there's like, I don't know how to draw this, I'm sorry, like a water seal section that's just gonna be a blue square. What this does, the purpose of this is to prevent air from like getting back up in there. So it's like kind of creates like a one-way valve. So like air can't get through the water and like back up through the tube, right? So like it creates a seal so that air can't go into the chest, because we're trying to drain everything out. And then you will see some bubbling in this water seal. Bubbling is can be good or bad depending on what's happening. So if you see bubbling happening in the water seal when the patient is exhaling, like forcing air out of his lungs, you might see bubbling, which is good. That means that air is exiting the patients from their lung and going through the tube down. The air is coming out here and the air is coming out to the water. Does that make sense? It's like, okay, that makes sense. When they're exhaling, air is being forced out of their lungs through the tube into the chest tube, right? So that's fine. Same thing with coughing. Like when you cough really forcefully, it's like pressure, so it forces air out of the patient's lung down the tube into the collection box. So those are good. If you see bubbling with coughing or exhalation, expiration, those are fine. If you see continuous bubbling, just like regardless of whether they're breathing in or out, this is where you could possibly have a problem. You could have a leak. So let's say this is my chest tube going into my chest, right? And air goes hopefully from the lung into the chest tube, or down the tube into the collection unit, right? If the chest tube comes out a little bit and like now it's open to the room air could be getting into the tube from the atmosphere and going down. So you might be just seeing air from not the patient, but like from out if it's dislodged, right? So you shouldn't see continuous like bubbling. If it's just like constantly bubbling, it's like, okay, well, why is all this air? You know what I mean? So it should be only, with coughing, with exhalation, not continuous. So if you see continuous, it could be a leak. It could also be if they're on a ventilator. Sometimes like the ventilator settings, you know how some of them, like if they're on PEEP or something, they could be pressing air into the patient even when they're exhaling to keep their alveoli open. There's PEEP, positive end expiratory pressure. So a lot of the times patients are put on PEEP when their alveoli are collapsing when they exhale, and we don't want them to do that. So what the ventilator will do is like force air into the alveoli to keep them open from collapsing, and then that will cause air to be forced out. So if they're on a ventilator, what you can do, because you're not sure if it is the ventilator or is it a leak, what you can do is turn off the ventilator for a few seconds. They're not going to die, but just a few seconds. I know if you're like, oh my gosh, they're not going to breathe. Like you can hold your breath for like a minute, right? So you can turn off the ventilator for like a good 5-10 seconds, see if the bubbling stops. And if it does, then it was the ventilator that was causing the continuous bubbling. If it doesn't, then it wasn't the ventilator causing it, and it might be a leak. The chest tube might be dislodged somehow. Does that make sense? Yeah. So those are the two possible reasons for continuous bubbling. And lastly, if now let's say the bubbling, there's just no bubbling at all, like zero bubbling. Two things you want to think, kind of like the same thing with the drainage. Okay, did it like slowly peter out or did it just abruptly stop, right? It could be a blockage, like let's say that the tube is blocked with a big blood clot or whatever. No air or drainage is gonna be able to get down there, right? So if there's no bubbling, it could be that the chest tube is blocked, or it could be that they've healed and that all the blood is drained out and it's closing up and they're healing. So it's kind of like using your nursing like critical thinking, like, okay, has it kind of been bubbling and kind of slowly stopped, or has it been like a lot of bubbling and all of a sudden it just stopped out of nowhere? So kind of thinking about those type of things. Does that make sense? Any of that confusing? Okay. And then lastly is the suction. So there's a wet and dry suction, right? The wet suction is basically like there's a section in the chest tube. I'm just gonna draw something here where they'll pour water into it, and depending on how much water is in there is going to determine how much suction there is. Don't ask me how water causes suction because I don't know. I really don't know. I'm not a respiratory therapist and I maybe should know this, but I don't. So like if they put, I don't know, the doctor will order how much water they want to be poured into this water chamber section. So you could have like a lot or a little bit and that'll somehow control the suction. Don't know. Or there's the dry suction where there's like a little knob on top of the chest tube. And you can like adjust it with like little numbers, how much suction you want. It'll, and the suction helps to pull and kind of suck either the air or the fluid out of the lung instead of just by gravity, right? If it, that's the other thing, gravity. We definitely want to make sure the chest tube isn't like chilling on the bedside table because nothing's going to go uphill, right? You want it to be down, kind of like the Foley bags, down below the patient so gravity can work. Gravity is also really great because they can like walk around, you know, but if they're hooked up to like suction, like on the wall, you know, like they have like the wall suction for like sucking out trachs and things, then they're kind of stuck. They can't really walk around. So gravity is preferred in some cases where like if you want them to kind of walk, because walking promotes healing, promotes exercise, all that stuff. But if they're hooked up to the wall suction, they can't like walk around and stuff. So let's say they are hooked up to wall suction, and how like behind the beds they'll have like little suction, and they can like, they use them for pure wicks, they use them for suctioning out trachs and different things. Let's say that the wall suction is set to like 100 and this suction on the box is set to 30. Which one of those is the right number for how much suction they're getting? And it's okay if you don't know.
I don't know.
It's always what's on the box, right? So this can be whatever suction level it is, but what matters is what the box is set to, the chest tube. So like mistake people might make is like, oh, the doctor ordered 20, I don't know what the unit is, 20 millimeters, 20 centimeters, 20 centimeters of suction, and they'll look at the wall suction and be like, set that to 20 and not realize that this is something else. So like whatever's on the chest tube is the suction, right? Because this will adjust whatever suction is coming out of the wall. So it doesn't matter if they have a dry, if they have no water, if they have no wet suction, it's just dry. It doesn't matter really what the wall is set to. If they do have a wet suction, right, and they're also hooked up to the wall, it still doesn't matter necessarily, except if this is really high, it'll cause the water to eventually evaporate because of all that like suction in the air movement. So it's still going to be, the suction level is still going to be based on the level of water that's here, not what's on the wall, right? So it's either the level of water, and you're going to be like different measurements of water on the side. And so you can either have this much or whatever it is. So this is going to be the suction, not the wall. This knob is going to be the suction, not the wall. The wall doesn't really affect it, but if you have really high suction on the wall hooked up to the wet, it can cause the wet to evaporate. So just keeping that in mind, like maybe don't turn it up so high because it doesn't affect it anyways, so just turn it down. Or make sure that if it does evaporate, you like make sure it goes back to where it's supposed to be. Does that make sense?
Yeah, so with the wet, there's no dial on.
Nope. Nope, the dry has a dial and the wet just has a level of water. So they'll either say water level to here or water level to here. And again, I don't really understand that. My brain doesn't understand water physics, but that somehow makes suction. So yeah, dry dial, you think D&D, dry dial, and then I don't know, wet. Wet water. There you go. Wet water. Water is in fact wet. Does that kind of help?
Yeah.
I know that like when I first looked at this, I was like, what are they even saying? It was very confusing. But hopefully this kind of explains a little bit. Because they'll have this, like this is the chest tube going up to the patient, right?
Yep.
Patient, and then they'll have like the suction tube going to the wall, right? If they're on that, or gravity. It could be gravity or suction. And so if they are on the wall, just remember that this number doesn't affect the actual suction level. It's either what the water is or the dial is. That's it. Okay. What else? Okay. So what do you do if you walk in the room and you see your patient has ripped the tube out of himself, like your lovely patient did? What do you do?
Well, you put the tube in like normal saline.
You want to keep it sterile, right? They're probably going to actually have to replace the whole thing because you can't just stick it back in there, right? Because it's dirty now, because it's supposed to be sterile, right? So the first thing you want to do is focus on the patient, because the whole point of them having the chest tube in the first place is because they have like an opening in their lung, and we want it to be like a contained unit. So now it's open to air, so air could be rushing into their lung, making their pneumothorax worse. So what you want to do is get an occlusive dressing and slap it on there immediately. That will prevent any air from sucking in. You know, as they breathe in and breathe out, it's going to suck air into that gaping hole. So that's bad. Don't want that. So if they pull that out immediately, like slap on an occlusive dressing to keep it from getting worse. You could, I mean, it's not wrong to stick the tube in like sterile water or whatever, but most likely they're going to replace the whole unit. But they're gonna have to re-put it in, like in surgery. You know, they can't just stuff it back in there. Now, what you're thinking of is if the tube disconnects from here. Let's say like this tube connecting to the chest tube drain itself, like comes dislodged right there, and now it just like pops off from the box. So maybe you're draining over the floor, right? Because it's not hooked up to the box anymore. That's when you would stick it in the sterile water, because that makes a seal. Right, because right now you have an open tube that's supposed to be in a closed chest tube drain unit, but now it's open to air. Again, that's no different than like their chest being open to air. It's just now they have a tube that's open to air. So again, air can be sucked through the tube right back into their lung. So sticking it in sterile water creates a seal, right? It's like putting an occlusive dressing on their skin, because the air can't go through the water and up the tube, right? So like putting it in the sterile water, it has to be sterile because it's a whole sterile thing. You don't want to be, you know, shoving random things into the side of their body. And then you'll have to go get a new, you know, chest thing and put it back in as soon as you can immediately. Does that make sense? So I think that's pretty much it. I don't think there's much else. Let me just make sure. What's the recommended suction level for suction?
Maybe 20.
20, yep. You know, just make sure like the patient's not laying on the tubes, doesn't get kinked and blocked. Make sure it's below them for gravity. Monitor for subcutaneous emphysema because it might have gotten dislodged. Look for tracheal shift. Those are things you're just going to be monitoring for. Yeah, and that's all I have. Is there anything else? Cool. Well, that was lung cancer and chest tubes. I'm going to stop this recording.